Thank you everyone for joining us. This is, I think, our first webinar of 2026. And we're pleased to have Dr. Eric Gillis be the fellow presenter. First, I'll introduce our two experts with us today. Dr. Ohja is a professor of neonatal medicine at the University of Nottingham and a consultant neonatologist at the University Hospitals of Derby and Burton NHS Trust. She is the research lead for the British Association of Perinatal Medicine. She's a director of clinical academic training and lead for the NIHR Children's Research in the East Midlands in the UK. She's the chief investigator of the FEED1 trial that we're going to be talking about today. Her main research interest is in infant feeding, particularly the promotion of enteral and mother's own milk feeding in preterm infants. She has expertise in clinical trials and epidemiology, and her research projects, including the FEED1 trial, are funded by the UK NIHR. Thank you for joining us. We're really excited to have you. And then Dr. Salas is an associate professor of pediatrics at the University of Alabama at Birmingham and an attending neonatologist at the Children's Hospital of Alabama. He's a clinical investigator with expertise in randomized trials of enteral nutrition in preterm infants. His list of peer-reviewed publications includes more than 60 manuscripts. He's a member of prestigious societies, including the Society for Pediatric Research, Perinatal Research Society, and the American Society for Nutrition. He receives grant support from the NICHD, the Gerber Foundation, Reckitt Mead Johnson, and he's currently the president-elect of the Southern SPR Society. So thank you also, Dr. Salas, for joining us. And I'll hand it over to Dr. Gillis to start his presentation.
All right. Thank you, Dr. King, for the introductions. As he said, my name is Eric Gillis. I'm a second-year neonatology fellow at Augusta University, and we'll go ahead and move forward and start talking about this trial. All right, so this trial that we're going to be covering is full exclusively enteral feeds from day one versus gradual feeding in preterm infants, or the FEED1. It was an open label parallel group multi-center randomized superiority trial. And so before we kind of start talking more in depth about the trial, just wanted to say I don't have any financial disclosures, conflicts of interest associated with this presentation. And then just to go into a little bit of background, when we talk about preterm infants and kind of what to expect, these studies really focus on not only preterm, but also low birth weight infants. And these infants in particular have a lot of physiologic and metabolic stresses, along with low nutrient reserves really early on in life. And so traditional preterm nutrition usually involves IV fluids, parenteral nutrition, and usually a pretty gradual or a cautious increase in enteral feeds, often over a set period of time. Many places will have feeding protocols set up that specify exactly how much of fluids versus how much of feeds are going to start at a certain time, and that usually gets gradually advanced over a period of days to sometimes weeks. And a lot of clinicians generally worry that starting these infants on feeds too quickly can lead to some consequences, such as necrotizing enterocolitis, which we all know is fairly severe, or really even just sometimes we're worried about feeding intolerance and the fact that I think the infants may not be able to tolerate the increased feeds. So starting looking at some of the background papers that cover this, I wanted to start out with the Cochrane review. This was published back in December of 2020 that covered early full enteral feeding for preterm or low birth weight infants. So this study goal as a review was to determine how full enteral feedings compared with delayed or progressive introduction of enteral feeds affects growth and adverse events such as necrotizing enterocolitis in these really small or premature birth weight premature babies. So they looked at randomized controlled trials that were comparing early full feeding versus the gradual feeding approach, which most of the time is defined, the full feeding is defined as usually 60 to 80 milliliters per kilo per day of enteral feeds versus gradual feed, which is usually 20 to 30 mLs per kilo per day of enteral feeds, supplemented with additional IV fluids or parenteral nutrition. With this Cochrane review, they looked through not actually that many studies on this topic, but what they found as far as randomized controlled trials, where there were 6 different trials they looked at, all were undertaken in the 2010s in neonatal care facilities in India. There are a total of 526 total infants, and most of these infants or participants were very preterm infants with a birth weight between 1,000 and 1,500 grams. In general, these trials were pretty good methodological quality. So they randomized the babies, they kept track of things pretty well and had a pretty organized approach. But there was a couple things that made these trials, I guess, less applicable. One is that they weren't able to mask the babies. It's very difficult to either be giving a full feed with minimal IV fluids or the gradual feeds like the normal approach without masking. It's almost nearly impossible because everyone at the bedside is going to be able to tell whether they're getting IV fluids at a higher rate or not. Um, these trials, they did look at the feed volumes and they advanced them daily as tolerated, as is pretty much is pretty standard in most NICUs. And they gradually advanced those up to, they determined full feeds to be 150, with some trials going all the way up to 180 milliliters per kilogram per day for these babies. What they saw, and this chart in particular actually just looks at the duration of hospitalization, but there are a couple other results I'll mention in a minute. But if we look at the duration of hospitalization, we can see that based on these 6 trials, there does appear to be some reduction in length of stay. And looking at some of the other data as well, I didn't pull up too many charts, but it actually showed that there wasn't any correlation between early exclusive enteral feeds and necrotizing enterocolitis, and there was a slight actual reduction in the risk of invasive infection and feeding intolerance. So actually, really, the study showed that starting these early exclusive enteral feeds could actually be beneficial and didn't really have any major consequences associated with it. That being said, the data from these studies is pretty varied and really not the best quality in general. The studies themselves are pretty heterogeneous and had fairly low populations in general, in addition to just being single center studies, excuse me, all from a single country. And so that does kind of prevent us from being able to uh, make these results very generalizable to NICUs around the world, um, where practices may differ, and you can expect to see different populations and different approaches. The other thing that I wanted to bring up is that they did keep track of the risk of the bias, and as we can see here, almost all the studies did not have blinding of the participants or the blinding of the outcome assessment as well. And so everybody kind of knew what they were looking for in these situations as well as what babies were doing what. And so that does hamper the accuracy of the results a little bit as well. The next study I wanted to talk about in the background was actually published by Dr. Salas, so he'll probably have some input on this, but it was published in June 2024. And it was looking at comparing the effects of early and exclusive enteral nutrition with either maternal or donor milk in infants 28 weeks and 0 days to 32 weeks and 6 days. And so this was a parallel group, unmasked, randomized control trial at a single tertiary NICU. They did have 102 infants, and they randomized to, as kind of the similar as the other studies, to either 60 to 80 mLs per kilo per day, which was the intervention group of enteral feeds, or 20 to 30 mLs per kilo per day of the enteral feeds with supplemental IV fluids. And this in particular, an important note is that they set the kind of the time frame to reach this at 36 hours of life. And so their primary outcome they were looking at was actually the number of full enteral feeding days in the first 28 days after birth. Some of the secondary outcomes were to look at this similar number, so the total number of feeding days in the first 2 weeks of life, and then as well as the length of hospitalization. And so as we can see from some of these numbers, I'll focus first on the length of stay, just because that's kind of the primary outcome of the FEED1 trial. But we see that while there did seem to be a clinical difference in the length of stays, in the length of stay in days, excuse me, it didn't quite reach statistical significance. We can see that p-value of 0.08. And so if we had a higher population, would we have seen an actual statistical difference? Maybe. But the other points that I wanted to look at is we did actually see an increase in the number of days of full enteral feeding in the first 28 days. So this is showing that starting these babies on full enteral feeds sooner did lead to a greater number of days on full enteral feeds in that first 28 days of life. And then we actually see that there may actually be reduced hospital costs associated with this as well. With starting earlier on those exclusive enteral feeds, as you would suspect, will decrease the amount of days they need IV fluids or parenteral nutrition, and that can lead to some lower hospitalization costs.
All right, thank you for highlighting those two findings. But I think I need a little bit of context, because you pointed out that the length of stay didn't differ, but there was cost differences. That was primarily driven by an early transition from an ICU to the step-down unit. So when we look at costs, even though the overall length of stay didn't change, they were babies in the intervention group were being transferred a bit earlier to the step-down unit. And I think, I'm sure Shalini will expand on, what length of stay really means, because it just captures so many of the factors. But for us, the difference in cost, despite no difference in length of stay, was mainly for that early transition to a step-down unit. Now, full feeding, briefly, and I think you did it right. So we're looking at the total number of full enteral feeding days in the first 28 days, so not time to full feeds, because we expected that, if you start with more volumes, you would get to full feeds earlier. But that's not the outcome here, right? So it's once you get to full feeds, how long do you stay on full feeds after that? Because there's always that concern that, yes, you can get them to full feeds earlier, but then they might be NPO for the next 7 days because, someone's concerned about it. So, yeah, so this means that 30 out of the first 28 days in the intervention group were on full feeds, which meant that there was no more intolerance after reaching full feeds. That was it. Thanks for summarizing all that.
Yeah, no, thank you. And I agree. I think that's a great point to point out, is that with a lot of these concerns that people may have with feeding intolerance when you start these babies on feeds sooner, you're right, the study does show that that's probably not as big of a concern as we previously suspected. The next thing I want to talk about a little bit is early exclusive enteral feeds in 30 to 33 weeks gestation infants. And this one was published in February of 2025. This study goal was to evaluate the feasibility of early exclusive feeding in infants 30 weeks and 0 days to 33 weeks and 6 days, with their primary outcome of time to reach fully enteral feeds. So differs slightly from that previous study. This, once again, infants were randomized to either exclusive enteral feeds or early exclusive enteral feeds at 60 to 80 mLs per kilo per day, or to the conventional feeding at 20 to 30 mLs per kilo per day. This study did have 70 infants. The results really showed that infants in in the early exclusive enteral feed group did reach full feeds faster. And so we can see that here with these charts. The other point to keep in mind, though, is that while these infants did reach feeds faster, they also, along with all the prior studies, did not show any increase in the rates of necrotizing enterocolitis, and really no other associated negative effects with increasing these feeds faster. Some limitations of this study, it did have a lack of masking, which we kind of see with a lot of these studies just because it's a very difficult thing to do. And then the primary outcome, as we said, that time to reach the full enteral feeds, is kind of a measure that we can reach, but it doesn't always necessarily assess the whole picture behind how these infants tolerated the feeds versus growth and other factors associated with full feeds as well. The study did also have some difficulty just because it took place during the COVID pandemic. And so they had some struggles with getting data, and that led to kind of a lower population that was enrolled. And so they did work with the data that they had. So kind of as a summary for a lot of our background information, randomized controlled trials that have started these infants on early exclusive enteral feeding show that in general, they reach these feeds faster. They tend to have a shorter hospital stay, and don't really have any increased rates of necrotizing enterocolitis. But some of these studies were kind of on the small side and not all fully sufficient to determine if full milk feeding compared to gradual milk feedings affects a lot of important outcomes, including long-term development.
Before we talk about FEED1, Dr. Ohja, I want to hear from you about the background. Obviously, the last two trials, were published long after you guys were already, full underway in the FEED1. But with the Cochrane review, I think the context is the most interesting thing for me, right? You have all these trials that show, benefit, but all of them are in India, and you're practicing in a different context. We're in a different context in the United States, and I think oftentimes when we think about low and middle income countries and other countries, we think about taking interventions that we've developed here and bringing them there, like Helix and cooling. But we've also had some good success with going the other direction, and I think this is maybe one of those potentially.
Absolutely. The idea absolutely came from the trials in India. And the results of those initial, albeit small trials, were very encouraging. The reduction in length of hospital stay was quite remarkable. But more importantly, the fact that they were not seeing even the slightest signal of increased risk of necrotizing enterocolitis was very encouraging for us, bearing in mind that the preterm population in India is more likely to be at a higher risk of complications such as necrotizing enterocolitis and late onset infections than you and I might be seeing in our NICUs in UK or US. So we were very excited when we saw that. And there was almost a temptation to say that, well, there's this evidence, why don't we just do it? And what really made us stop was, as they say, the devil is always in the detail. If you look at the length of the stay that the Indian studies were reporting, the median length of stay in these studies were around 15 to 17 days, both in the full milk as well as in the gradual feeding arm. And when we looked at our data in the UK, the 30, 31, and 32 week infants who we were interested in, they stayed for a lot longer in the hospital than that. Our median stay at that time from our national research database was closer to 35 to 40 days. And that immediately made us think that that might not be something that we can directly take from research in India, and a UK-based study was required. And as you've pointed out previously, both Ariel study in Birmingham as well as the Canadian study, both of them were designed, started, and finished while we were still recruiting, because that's what happens when you do a large randomized controlled trial. You have to give up a large chunk of your life to do it. But it was really encouraging to see that coming on while we were recruiting, for two reasons. For me, it was, first of all, really encouraging to see that other people were interested in this idea, which meant that if our trial showed something, there would be interest in taking it up in clinical practice. And secondly, small, but again, beginning to see some evidence to say that even in our setting, NEC was not going to be an issue, because that really was, like, same as every other clinician, the biggest fear that we had when we designed and conducted the study.
Thank you, Dr. Ohja. That was some great insight. So now moving kind of on to the FEED1 trial. Their primary study objective was to determine whether these full milk feeds in preterm infants ages 30 weeks and 0 days to 32 weeks and 6 days gestation on day 1 of life would lead to a decreased hospital length of stay compared to infants of the same gestational age receiving those gradual milk feeds. So again, our population, it differed slightly from some of those studies that were previously done, just focusing on 30 weeks and 0 days to 32 weeks and 6 days. The intervention was the full milk feeds from birth. Important note is that these full milk feeds per the intervention had to be initiated at less than 3 hours of life, versus the gradual feeding with supplemental IV fluids or parenteral nutrition. The gradual feeding group, which is less than 30 mLs per kilo per day on day of life 1, with supplemental IV fluids or parenteral nutrition as our control. And then our outcome, the primary outcome, is hospital length of stay. And then the time frame is following up on all these outcomes at discharge. And then also some secondary outcomes were additionally measured at 6 weeks of, corrected 6 weeks of age. So most of the time close to 6 weeks after discharge. Looking at our inclusion and exclusion criteria. So to be included, you had to be 30 weeks and 0 days to 32 weeks and 6 days, less than 3 hours old at the time of enrollment. And then a couple of the exclusion criteria was infants with known congenital anomalies of the gastrointestinal tract or other congenital conditions that made enteral feeding unsafe. Those infants were excluded. And then also infants that were both small for gestational age and had reversed end diastolic flow on antenatal umbilical artery Doppler ultrasonography. And so those infants that were small and had those ultrasonography findings were excluded. And then infants of mothers who had previously participated in the trial with a prior pregnancy were also excluded. Something that's kind of important to note is that the supplemental feeding options were not included here as inclusion criteria. So whether the infant was going to be fed with maternal milk or donor human milk or formula did not matter for the inclusion criteria of the study. And then kind of looking back at some of those previous studies, Some of those had pretty similar inclusion criteria and exclusion criteria, but a little difference is that some of them looked at whether the baby was on mechanical ventilation or not and excluded some of those babies. But in our study here, they didn't take that into consideration. So no matter what type of respiratory support they were on, they were eligible for inclusion in the study. Looking at our study design, so this is mentioned in the title, but it was an open label, parallel group, multi-center, and randomized superiority trial. Recruitment was from 46 different neonatal units across the UK. The enrollment period was from October 2019 to July 2024. And then the outcome data was collected, most of it at hospital discharge. As far as the randomization, it was performed with the mother. And so for multiple birth pregnancies, all the infants had to be placed in the same treatment group. This did cause a little bit of factors that had to be considered. And so they actually used this web-based system where they used a minimization algorithm that had a random element to ensure balance. And so kind of this minimization algorithm, what it does is it still has a certain percentage of these babies that get enrolled in study that just automatically get randomized to one of the groups. But it also takes into account the site, whether it's a single or multiple birth, gestational age, whether small for gestational age. And it looks at those factors and tries to keep the groups balanced. And so a lot of these babies that are enrolled, the system will look at what babies have already been enrolled and will try to keep the groups as balanced as possible, keeping those factors in mind. That being said, even though it tries to balance it, it does still have a certain amount of randomness to it. So some babies that get enrolled, there's a certain percentage of chance that they just still get randomized to a group. So this is helpful because it does actually make sure that these groups stay pretty balanced, as well as continue to ensure randomization. It can be something that people look at and say, well, maybe it's not as random as you might get otherwise, but it does make sure that all these groups end up being relatively similar and you're not going to see differences in these groups just by random chance. So the primary outcome that we were looking at was the length of hospital stay, which included the total duration of any neonatal unit measured from the day of birth to the day of discharge. Because it's not really feasible to set the discharge criteria for all 46 different neonatal units, what they actually tracked in addition to that, just to make sure that there weren't significant differences seen, is they tracked the time until objective discharge criteria were met, and they set that criteria as a current weight of at least 1,700 grams, the ability to take at least one full suck feed, and not receiving any additional temperature support for at least 24 hours. And then looking at some of our key secondary outcomes, they looked at survival, they looked at the incidence of NEC, the incidence of sepsis, hypoglycemia, and then whether or not the babies continued to get mother's own milk up to hospital discharge. So in order to detect a group difference with a length of hospital stay of 2 days with 90% power, 1-to-1 allocation, and 5-sided, 2-sided significance, they kind of set certain parameters. They set these parameters, and to reach those numbers, they had to get just under 1,800 babies. However, because they were randomizing with mother, and that meant that if there are multiple pregnancies, like twins and triplets, and those babies had to go to the same group, they did actually inflate that number by 15% just to account for that intercluster correlation coefficient. Essentially, that looks at how similar and different are the babies in that group going to be compared to the total variance between all the babies or all the groups. And so they figured 15% was enough to account for that, and then also increase that number by 2% just for expected possible non-collection of primary data. And so with that, they came to needing a total sample size of 2,088 babies. They did, looking at statistical analysis, they analyzed these using mixed effects regression models that accounted for random effects of mothers and research sites. And essentially what this means is that they look at the different sites individually and kind of combined as well. And so instead of just combining all the data into one big group, it looks at all the data, but then also says, well, we're different sites, slightly different, and it allows them to see kind of how those sites interact with the data in between itself, as well as then comparing those individual sites to all the other sites and all that data. And so they can look to see, well, did these have different baseline characteristics associated with a certain site versus not? And then they did also collect some data, and they used exploratory non-randomized analyses. And essentially what that means is that they didn't plan to really prove any conclusions from this data. It's mainly to look at this and see, are there any trends that we could look into with later studies.
Can you, Dr. Ohja, just give us some context? There may be some UK people in the audience, but if primarily people are from the US, or at least what was the state when the FEED1 trial was started in terms of supplemental nutrition for this population range in the UK units? Like how much variation was there in donor milk use across these sites?
Donor milk had already come to a large number of units by the time we had started. So in 2019, you would have about a third of UK units would not have had access to donor milk. So most would have. In the trial, we did, however, have some quite large recruiters who had no access to donor milk or chose not to have access to donor milk in that period. Particularly the region in which I work, East Midlands, we had 3 large recruiting sites and we were not using donor milk at that point in time. By the end of the trial period, all 3 units had adopted the use of donor milk. What we also saw is that a lot of sites opted to give the 30 and the 31 weekers donor milk, while the 32 weekers, even if they were randomized to the full milk arm, were given formula milk. So there seemed to be quite a variation. We've got data on individual babies as to who got which kind of milk as a supplement, but the practice was quite variable. There were also some sites where the standard practice at that time had been to give donor milk to 30, 31 weekers and formula to 32. But for this trial, being a bit risk averse, they went for donor milk for the whole population. So we had a mix. But I think you made the point earlier, Erik, about randomization being minimized by site. We were very keen to do these, to allow clinicians to embed the trial in their routine clinical practice so that we could have what is called a pragmatic trial design, which has certain disadvantages in the sense that it makes the trial a little bit less scientific from a rigorous protocol being implemented point of view. But actually, when it comes to translation into clinical practice, there is a huge advantage there because we are now no longer saying that this only works if you use donor milk or this only works if you use formula milk. What the trial results can be generalized to is whatever your feeding protocol in your unit, these are the results, and these results are applicable to you.
Yeah, no, that's a great point, Dr. Ohja. And I am going to bring that up a little bit later, but since you brought it up now, yeah, that is one of the things that I think is, as you said, from a statistician's point of view, they may say, oh, well, this isn't as random or this isn't as specific as it could be, but I do think it adds a lot to that generalizability of the study, just being able to look at these results and know that, yeah, some centers used donor milk, some units used formula. But despite that, these results took all that data in, and this is what we saw. And we'll get to those results in just a minute. This is a slide just kind of covering, as we see, it had 2,088 infants, 1,048 went to the full milk feeds, 1,041 went to the gradual milk feedings, and then all other feeding related care was just performed according to local practice, as Dr. Ohja said. And I did just want to mention that development of this trial was also done with a collaboration through an organization known as Bliss, which is an organization that helps families of infants that are born premature. And so they helped had some input in on some study design and some particular points that parents may be interested in knowing for their infants. And so that was also taken into account. Just looking at the flow sheet here, pretty standard. You can see that there's a lot of potentially eligible infants. They approach the mothers. It is I think it's kind of cool that they approach the mothers and get the consent before. That also means that a certain number of these infants who were consented didn't end up being randomized. And part of that is that either the mother did not deliver before the time frame, and so the babies were then too old to be enrolled, or they found new findings on ultrasound that excluded baby from the study. Of the 1,761 mothers, there were 2,088 infants. And as we can see, they actually had very good recruitment and very good follow-up on the data. I mean, really only 18 from each group not being available is actually less than the 2% that they accounted for when they increased their recruitment goals. And so really 1.7% of infants in each group that had the primary outcome data missing, which is excellent. This is a table I kind of condensed, from table 1 in the paper, but really it just shows that for a lot of these important baseline characteristics, there was no significant difference between groups. And part of that we can attribute to the large sample size, and part of it to that minimization randomization protocol that was used. So moving on to results, here we can see that the primary outcome, which was time to discharge, this is the graph on the right, there actually was no change or difference in the time to discharge between the two groups. Time to stopping IV fluids, as we see in the graph on the left, we see that the babies that were started on exclusive enteral feedings was much shorter. And so looking at this, we can see that let me see if I can grab a laser pointer here, but we can see that a good percentage of these babies, about 20%, were actually never even started on IV fluids. They were just able to get only on those exclusive enteral feeds from birth, and never had to be started. A couple of these secondary outcomes that I wanted to point out is that we look at the rates of necrotizing enterocolitis before discharge, and there was no difference between the groups. Exactly the same. And then the other box that I have circled there is the time to full enteral feeds. We see that it was decreased in the babies that were started on early exclusive enteral feeds, those full milk feeds. And then the time to objective discharge criteria met, we see is also the same. So even though there's different practices between different institutions and different units, we see that despite those different practices and maybe some units discharging later than others, we see that that time to objective discharge criteria was the same in both groups. And then the other result that's in that second box, we can see that the amount of parental nutrition that was needed until discharge was significantly less in the babies that were on early exclusive enteral feeds.
There's another outcome that I think we should highlight here too, because it's right there, and that was the exclusive breast milk feeding at discharge. Because there was this concern that, if you offered donor to achieve higher volumes too early, would that affect breastfeeding? Would that discourage moms from actually pumping milk or affect breastfeeding? I think here, with this large sample size, we have evidence that we also found in our own study, which was there was really no effect of offering donor milk early on at higher volumes on breastfeeding at discharge, because that's sometimes things that come up as you think about how to implement this. There are concerns from nursing or dietitians. Is this going to affect moms' milk production or delivery throughout the NICU? And that doesn't seem the case. And one of the explanations we had, at least in our trial, is that because we were consenting so early, we were talking about the importance of breast milk on day one, right? So maybe having that conversation was actually a good commitment to realize that, donor is a bridge, that breast milk is best, and that they parents would know that that's important for us, make sure that they provide their own milk.
Thank you. No, that is an excellent point. Other point I wanted to just talk about on the slide is that keep in mind that some of these points kind of below, if we're looking at parental nutrition until discharge and the number of IVs, things like that, if we account for the fact that about 20% of these babies did not ever need an IV, they actually used a zero inflated model, a negative binomial model that accounted for all those zeros and kind of takes that into effect when they looked at some of this data as well.
If you go back to that table, since Ariel pointed out an outcome that he liked, I also, there's a lot I think in here that's great, because I would also point out, you may have said it, but you didn't highlight it, is the central line data as well. Right? Like, because you think about outcomes that are also important to families, maybe, like, not needing needing fewer cannula in general and also needing fewer central lines and fewer central line days. Those are all like, I think, great things, regardless of what happens to length of stay, like to be able to do that. So those are also really important.
Yes. Yeah. Thank you, Dr. King. Looking at just kind of the forest plots for a couple different factors. And so this looks at length of stay on the left, late onset sepsis in the middle, and necrotizing enterocolitis on the right. And we actually see even for all the age groups, it breaks it down from 30 weeks, 31 weeks, and 32. We actually don't see any difference between the groups, between those that got full milk or those who had gradual feeding. So no increase in the amount of necrotizing enterocolitis, no increase in the rates of late onset sepsis, and as we already specified, no increase in the length of stay or decrease in the length of stay. One thing I did also want to bring up is just adherence rates, and this was kind of in the—
Can I just,
Yes.
sorry, Eric, can I just make a point about the previous slide?
Yes.
I think that I find this image this figure very interesting for what is not in it. And what is not in it is the subgroup analysis for necrotizing enterocolitis for SGA babies. Because I think one of the most interesting findings that for me as a clinician was we had 242 SGA babies recruited into the trial, and the event rate for NEC was 0. And that's why we couldn't do this analysis. And that's the highest risk group that we were most anxious about recruiting and ummed and ahed about whether that should actually be an exclusion criteria for this trial. And we went on with it. Of course, 242 is not a big enough number to call it, any by any stretch of imagination, strong evidence. But I still think that it was very encouraging that none of those babies had any necrotizing enterocolitis cases.
And I would like to add there that, remember that lack of presence of the absence of necrotizing enterocolitis is not because we were not looking for it. Remember that, without masking, it's possible that our clinicians were looking really hard, especially when they have very strong opinions about just why are we giving too much volume to this baby. Maybe it's like there is a lot of surveillance bias in that particular group. So I think we have to acknowledge that the fact that the rates were so low in this trial, and that there was not even a signal in the considered high-risk population, means that despite all this perception that those babies will be at high risk and maybe actually got screened for NEC more often, they really didn't have any proven diagnosis, despite our traditional clinical perceptions that this would actually lead to more NEC.
Yeah, no, that's an excellent point. Thank you. Just to look at the adherence rates a little bit with the study. And so looking at full milk group and the gradual milk group, obviously adherence rate for the gradual feeding group was pretty good since that's classically kind of what we do in the NICU. But then in order for the full milk group to be defined as fully adherent, they had to be off of IV fluids by 24 hours of life. And so looking at this, we can see that for these babies, 61.5% of them were able to be fully off of IV fluids by 24 hours of life. And I mentioned kind of a point earlier, but we also know that about 20% of this group never got IV fluids to begin with. And so you may look at this and say, well, that's not great adherence to the group, but honestly, compared to what a lot of our infants get, it's excellent. When we look at the amount of milk volumes received as well, we can see that despite gradual feeding kind of catching up a little bit in this chart, we see that these babies did stay on average for higher milk feedings, highly daily milk feedings for over those first couple of days. They maintain that higher milk feeding.
I think this figure is important, right? Because unlike other protocols here, there was an intention to advance feeds daily, which is reflected in both groups. Remember that some units will have a protocol where they do trophics on these infants, right? So they not just would start on smaller volumes of 20 to 30 cc's per kilo, but they will keep those babies on those volumes for a bit longer, which begs the question, right? So what happens if my standard of care is to do 3 days of trophics? So then here, the box plot on in red would look like flat, right? So over the first 3 days. and that would make the intervention a little bit more, the effect size probably more obvious. Again, just keep that in mind. I think this is like a daily advancement approach, which has been promoted in the UK more often than in the US. So this was daily advancement, not trophics really in either arm. So.
That's a very good point, Ariel, and perhaps something we don't appreciate in the UK of how different practices between our two countries. Because by the time we were we started the FEED1 trial. Some of you may know we were largely the same team that had previously done the SIFT trial, and SIFT had been already implemented. So this was a population where trophic feedings were no longer being practiced at all. It was about starting small volume feeds on day 1 and going up by 30 mils per kilogram per day. So what was the FEED1's gradual feeding arm may actually be faster feeding than is practiced in many countries.
Yeah, no, that is a great point. Thank you for pointing that out. So kind of just as discussion and kind of going over these results, what we see is that infants in the full milk group reached full milk feeds at a median of 14 hours. So as we showed, there were a lot of babies that didn't quite make it to that full milk feeds on day of life 1, but the median was 14 hours compared to 99 hours in the gradual milk group. So a pretty significant difference there. Infants in the full milk group also had a shorter duration of receiving TPN and shorter times with indwelling central or peripheral intravenous lines. So that was something that Dr. King mentioned. And while it may not we didn't actually follow the direct results of that, but we can see that there wasn't any increased risk of infection or anything like that. And for a lot of these parents that are being there in the NICU with these babies, having those lines in for a shorter length of time can mean a lot to them. And then we saw that around 60% of the infants in the intervention group received IV fluids or TPN for less than 24 hours. And as I mentioned before, 20% of those infants did not actually need any IV fluids or TPN at all. Talking about kind of the primary outcome, I thought it was interesting that in this study, we see that there wasn't any difference in the length of stay. And so this is actually different from what we saw in some of those previous studies where it looked like the length of stay was trending to decrease with these early exclusive enteral feeds. And so I don't know if Dr. Salas and Dr. Ohja had any input on that or what their thoughts were about that.
Yeah, just to comment on that, I think we didn't find, as you said, it could not have been more similar, the length of stay in both the groups. And I think the reason for that is how far removed this intervention is from the time when we were measuring this, the outcome. And by the time a baby in our setting is ready to go home, having achieved full enteral feeds is something that has already been and done quite a few weeks ago. And there are other factors that affect discharge, which range from medical reasons, such as we included in that objective discharge criteria, but also social and family factors. A lot of babies are staying in, I hope, to establish breastfeeding, and I'm perfectly fine with babies taking a few more days in the hospital if they can go home exclusively breastfeeding at the end of it. And also, there are definitely, in my experience, there are so many social factors and family readiness that need to be in place and those become the predominant drivers of discharge, of the length of hospital stay towards the end of an infant's stay in the neonatal unit. And that's why what we did in the beginning, the fact that we were able to get these babies onto full milk feeds on day 1 or on full enteral feeding a couple of days sooner, did not really make a difference to this outcome, to this particular outcome. Yeah. As compared to if you look at the studies which have been done in India in a slightly lower resource setting where the competition for beds and resources is a lot more tighter than we are fortunate enough to see in Europe or in North America. There I assume is a rush to get babies out of the unit, which means that interventions in the first few days are more likely to have an impact on length of hospital stay than when the babies stay for a lot longer.
The one thing I would add about this is like, should we really see this as a negative trial, right? Because yes, there was no difference in length of stay, but you know, we've implemented a lot of things in neonatology with just the concept of non-inferiority, right? So if this would have been decided as a non-inferiority, we would say, well, this should be then the practice, right? But I think we have to be careful with that message, right? So yes, there was no difference on length of stay, but there were many other positive effects. There was definitely not a signal of harm. Why would link our commitment to implement this practice to superiority when we are aware that, you know, sometimes we are comfortable with non-inferiority? So, and again, I think, you know, if you address some of this issues with length of stay, you might actually see an effect. So I think there's a probability of benefit under certain circumstances, and definitely not a signal of harm. And as I said, I'm very I think the data on safety is pretty reliable because I know that we were specifically looking for it. You know, it's not like it was unexpected to see more neck. We were actively constant surveillance for that outcome, and it didn't really pan out. So I think, yeah, length of stay, yes, it was power for that outcome, but it doesn't mean that it's a negative trial. I've heard that interpretation before, and it's interesting to hear about.
To both of you as trialists, I think I want to keep talking about length of stay a little bit, because I think if we had talked before a year ago, we actually don't often have trials. And my perception is length of stay isn't a common primary outcome for our neonatal trials. And actually in a year we had this, and also the caffeine trial that that had MoCA had length of stay as the primary outcome and also didn't show a difference. And I think similarly, there are debates about, you know, what are the reasons for a length of stay and discharge, and so I think length of stay made sense as the primary outcome because that's what was the India trials were really showing, Dr. Ohja. But I agree with Ariel from the get-go. I kind of, in my mind, I would almost have wanted to think about this as more of a non-inferiority of a like, well, as long as it's not worse for these really bad outcomes that we're worried about, like why do we need to show benefit, right? Like all these small outcomes all add up to say there are all these small, the central line days, the breastfeeding not being different, the neck not being different. I think it makes a compelling case beyond just it not showing a difference in the primary outcome.
Absolutely. I mean, for me, the results of this trial, it's as the chief investigator, as you know, the person who's responsible for the scientific robustness of the paper that I'm writing at the end of it, there is an obligation, and we must always be faithful to that obligation, is to present the results as scientifically as it should be, wherein we had a hypothesis that said length of hospital stay will reduce. The results of this trial show that the length of hospital stay did not reduce. That's the very, you know, the precise scientific interpretation of this trial. However, as clinicians, we need to look at the wider aspect, as all of you have pointed out already. It's about what about all the other difference that it made. It didn't show any problems. It didn't increase the length of hospital stay. It didn't increase any of the adverse events that we were concerned about: necrotizing enterocolitis, hypoglycemia, you know, the more troublesome kind of feed intolerance incidences. And it reduced the burden of medical intervention on the baby and the family, would be one way of putting it. That's, for me, that would be an umbrella phrase for all the things: intravenous cannulations, central lines, IV fluids, parenteral nutrition, staying in the intensive care room itself, the joy of the family when they find out that their baby can now be moved out of this scary, noisy room into the nicer bit of the nursery. And if we can have all those benefits, does it really matter if they all stay in the hospital for the same time?
Yeah, no, I completely agree. And I know I kind of presented the question because a lot of times we look at these studies and if we don't see a difference in the primary outcome, we ask what changed. But when I was looking at these results, I agree that there's a lot of these small things that I think do add up. And the amount, I'm only a second year fellow, but the number of times that I've been at a bedside as we've sat there and tried to get an IV on this baby over and over, and the parents are standing there crying. I mean, if we can even reduce that number by 1/5, if there's 20% of these infants that actually don't need an IV at all, I think that's a very significant difference in not only how the baby is treated and interacted, but also how the parents are able to cope with having a baby in the NICU. And I feel like it's a lot of those little things that can add up and lead to a better stay, while also, as y'all have mentioned, not causing any adverse effects. We don't see that increase in neck. We don't really see any increased amounts of feeding intolerance or difficulty or additional negative effects from being started on these early exclusive enteral feeds.
Excuse me, this is Jeanne Nunes from UMMC. Probably the study was not powered to roll out neck as a primary, it was not powered for neck. But on the other side, we have to remember all the background studies. What's the evidence to advance progressively on feedings? It's just based on really small retrospective studies were done in the 90s, I believe, and they really included only few babies in each arm, and they were retrospective. At the time, we were using only formula and not breast milk, which we know is a major factor for neck. So we're trying. I believe that you're trying to undo some practice that were based on not at all any evidence. So now we are obliged to enroll thousands of babies to show that it's powered enough to roll out neck, when in the first place the studies were not at all good to demonstrate that progressive feedings were going to be a risk factor for neck. So I think we have to see the background here, and I think that study that you have done is impressive. Now, you stayed only you only studied babies over 30 weeks, but what about the smaller babies? And as you said, decreasing the risk of IV. What's the risk? What's the incidence of sepsis in babies? Is it more than neck at this point? Why are we subjecting generation of babies to IV fluid and PICC lines and UV lines? And we have seen babies dying because of PICC lines and UV lines. Why did we do them when it was never demonstrated that you would decrease the risk of neck by advancing slowly on feedings? So when are we going to do other studies for the smaller babies, the less than 30 weeks, or nobody is daring to try to do that? That's my question.
First of all, thank you very much for sharing your thoughts. You're absolutely right. A lot of these trials that we are doing now, we are trying to undo non-evidence-based practice, which, for want of a better expression, was fear-driven practice. We didn't want to harm babies, and in that process, we actually ended up harming many babies, and that's what we're trying to get out of. Yes, this trial was not powered for neck. It would have been practically impossible to do a trial in this population that was powered for neck. We did do the sample size calculation. Believe me, you don't want to know the sample size number that my statistician came up with. And that was for a very,
greater than 15,000 babies?
17,807.
Yes, that's what
I remember the number, even if it was nearly 10 years ago. You are right to ask where. For me, that is the question: is where do we go next? And we are already having some discussions about what I like to think of as the FEED2 trial, and the smaller babies maybe, or the higher risk babies at these gestational ages, the small for gestational age babies with and diastolic flow issues on antenatal Dopplers. And perhaps Ariel's study had 28 and 29 weekers in it. We did try in FEED1 to initially include 28, 29 weekers, but the clinicians who would have actually done the recruitment for us were not in equipoise about that population at all. But perhaps now that we have results of FEED1, as the next step, we should be able to look at a little lower gestation. I wouldn't go down to the 22 weekers, but at least 28, 27, 28, 29 to see if a similar strategy of exclusive enteral nutrition from very early in life would be safe and feasible.
We did some poll questions just to highlight for those who answered them. And this kind of goes back to, there was an earlier discussion about practices in the UK, but even prior to the FEED1 due to the SIF trial, And then Ariel pointing out that, maybe things are a little bit different in the US. I don't know, Ariel, if you've ever done like a national, it's always really hard in the US to get, information on how everyone's practicing to kind of see where people are at. But,
I got a couple of surveys. What's interesting, people answer, they try to find the right answer. I don't think they actually answer with their actual practice. Everybody wants to look good. And, I always wonder if that's a true.
But yeah, so the majority here are saying, full enteral feeds are, it's something that they would consider on an older gestational age infant, or at least that's been their current practice. And then that 20 to 30 per kilo starting range. I think another question would have been the advancement, who's still doing trophics in this population, like you mentioned, Ariel. I think big picture to me, that the discussion that was just brought up, I've often, when we talked in neonatology about this age range group, and also maybe like the 32 to 34 week infants as well, we often talk about like, do you treat them, do you take data from the smaller infants and apply it to the older infants, or do you take data from the older infants and apply it down? And it's sort of a glass half full, glass half empty sort of situation. And I think this study really, and a few others recently have kind of shown that, maybe we should be thinking more and more about how we can, push the non-intensive care envelope down, as opposed to just assuming that every baby needs, 3 or 5 days of trophics, et cetera, et cetera.
Yeah, thanks, Eric. Thanks for actually putting this review article there, because in this paper we kind of try to address the implementation phase. What challenges are we going to face, as we think about implementing this in a unit, right? So outside the clinical trial, I do see a lot of potential in terms of getting better at a lot of stuff. As you can imagine, consenting for a trial in general delays, the initiation of early feeding. Without that requirement in implementation, you could definitely get those, definitely maybe reduce even any survival placement. The monitoring also would improve. Fortification timing comes out, as a question. What if, when do you do it? And all the questions that we posted on this review article, I think, will be useful for whoever is considering implementing early enteral nutrition.
There's quite a good question, Dr. Ohja, in the chat from another Brian about that population that never received any IV fluids, or even if you expand it to the population that received like a very short period, and whether there's anything we can learn about those babies. If people wanted to take this, but they said, hey, maybe I don't want to apply to everyone, like what's that subgroup? Did you look at them specifically?
We are looking into this. So a couple of analyses that I hope to publish later this year. One of those will be this. The first, going back to the point that was made a little while ago, we are looking at analyzing data separately for those who were supplemented with donor milk and those who were supplemented with formula milk, because there's a lot of interest in that. And this is the second thing that we want to do. So we just take the babies who were in the full milk arm and divide them into those who were successfully fed, the 60% or the 61%, and those who were not able to meet our definition of compliance, which was fully milk fed within 24 hours, and see if there are any systematic differences between the baseline characteristics. And that is what I think should help us make that clinical judgment, or at least guide us in making that clinical judgment as to who to go for with full milk feeds for as soon as after they are born. This 20%, this 1 in 5 who absolutely did not receive any IV fluids, definitely going to look at them separately. I have a suspicion, however, that a little bit of this might be how confident the site staff were, how confident were the people who were randomizing. Because remember, we gave people only 3 hours, which is a very short span of time. And the practice in that 3 hours varied from some clinicians who said, well, we've got 3 hours to take consent. Let's hold fire. Let's not put an IV line in. Someone go and speak to the mother. Come back if she says yes. We'll just fully feed this baby. While there were others who would take because this was a trial, people were taking a bit more cautious approach and going, let's start the IV fluids. We have 3 hours to talk to this mother. So the 3 hours could have been interpreted either way. And some of that difference in clinician behavior may have driven who was in this 1 in 5 and who was the other 4. As we implement it in practice, I think it will be more than 1 in 5. Because once we know that we can do this, we don't have to wait for permission to do it, or we don't have to go through the randomization system. There is no risk of hypoglycemia. Let's just go ahead and fully feed this 31-weeker who looks very well. I suspect that it will be more than 20% who will not require any IV fluids or parenteral nutrition.
Erik, I want to make sure that we didn't, because we've had lots of great discussion, but want to make sure we didn't cut you off with some final slides.
I just had a couple more. We've kind of covered most of these points already. Just talking about the study, some of the strengths. It was a very large study. It was adequately powered and had enough participants to say that the full milk feeds do not affect the length of stay. And it was very robust. There was very little babies lost to follow up or that we didn't have results on. And from what I understand, we're still kind of continuing to follow these patients to kind of look at some of those more long-term outcomes as well in the future. And really, some of the main limitations is that, as a statistician might point out, they didn't have very detailed feeding protocols, and there wasn't really a mandated discharge criteria. But as Dr. Ohja mentioned earlier, this actually does help things a little bit in generalizability. Essentially, we can say, while they did not have these set feeding protocols, maybe it did not make the data quite as precise as it could have been. It does also make it a little bit easier to say, well, even though all these different sites did things differently, their data is still kind of matched up, and so ours probably will too. And then I just had a few conclusion slides, but we really already talked about these in general. As far as future direction, that editorial piece that I posted from Dr. Ohja and Dr. Salas actually talks about this a lot. So I won't really go into too much detail because I don't think we have enough time to really talk about things too much, but they had a lot of suggestions on how can we move forward with this? What things should we look at when trying to implement these protocols into our own institution, as well as kind of what are some possible studies that we could look at in the future that could help kind of define this a little bit better. And so really that's all
Thank
I
you so
had to
much.
share.
Any final words, Dr. Ohja or Dr. Salas?
Thank you very much, Erik. That was a brilliant job you did there, really well presented. Just one more point that I wanted to add is you've just mentioned that we are continuing to follow these babies up. We've already presented the data for 6-week follow-up, 6 weeks corrected age follow-up, and we are going to report 2 years survival without neurodevelopmental, moderate to severe neurodevelopmental disability at 2 years. We should be coming to the end of follow-up by July this year. And just to make the point that we are now doing more and more, as Brian, you said, studies where the primary outcome is length of hospital stay. And a lot of these are like FEED1, are open label trials. They're not blinded. And when we were designing FEED1, we were very conscious that the combination of these two could lead to a very dangerous bias. And hence the plan to follow up at 6 weeks. And I do think that any study that aims to reduce length of hospital stay must do that, because there's absolutely no point in sending these vulnerable preterm infants home sooner if they're going to bounce back in a couple of days into a pediatric ward somewhere else. For me, that is one of the limitations of the other trials that have been done in this area, where people are showing 6 to 7 days reduction in length of hospital stay, but not really finding out what happens after the baby goes home. So just a point, as neonatologists, we sometimes kind of limit our thinking to the neonatal unit, but there's about 75 to 100 years of life to come for most of our patients, we hope. And sometimes we need to think a little bit about that too.
Excellent. I just wanted to say that, I'm just hoping that we'll have more implementation of this practice and just start analyzing data prospectively and try to validate all this clinical trial data in real practice. So that's my hope, and I think we can make it happen.
All right, thank you, Erik, for the great presentation, and thank you, Dr. Ohja and Dr. Salas, for your insight and discussion. This has been great. Everyone have a good evening.
We'll see you again next month. Thank you.
Thank you very much.
Thank you.